So let's get started with valvular disease. Student learning outcomes there for you to read. I have to go over them all. Perfusion definition, basically the same as before. Perfusing oxygenated blood to the body and tissues. And the definitions that really apply to this part of the lecture are these listed here: stenosis, prolapse, regurgitation, and atresia. So stenosis would be when a valve doesn't open as it should, whether it be because some of the leaflets are fused together, maybe a congenital problem at birth, or the valve is thickened and stiffened over years, as people have aged. Stenosis makes it hard for blood to travel through the valves. Prolapse is when the flaps of the valves kind of bulge up into the atrium, which I can kind of show you a little video in a minute, which helps to visualize it a little bit better. But basically it kind of balloons up into the atrium. It's not working effectively when it balloons. And regurgitation is when you have a leaky heart valve, or your heart is pumping blood through a valve, and when it goes to eject it out into the systemic circulatory system, some of it leaks back up into the atrium. And then atresia is just it's not improperly formed, or there's a piece of the valve that's missing. So this little video I like because you can kind of see them all together except for stenosis. You can see the differences here. So this is a normal valve. It closes nicely there. There's no ballooning. Prolapse, it balloons up into the atrium, kind of bulges when it shouldn't. And then regurgitation, when the blood flow from the atrium is going to the ventricle, it goes down and some of it squirts back up into the atrium when it shouldn't. So that means the valve's not closed properly. That blood's leaking back.
Will the prolapse, could that turn into regurgitation?
Yes. Mm-hmm.
Or could you live perfectly fine with the prolapse?
You can, yep. So we'll go into that a little bit more in just a minute. And then the other definition is murmurs. These are abnormal sounds caused by turbulence within the heart, so when the blood flow is turbulent. And 3 factors that cause murmurs are when there's a high rate of blood flow through an abnormal or even a normal valve. If blood flow goes through a sclerosed or stenosed valve, you're going to hear it by murmur. And also when it's regurgitated, you can hear it kind of swishing when someone has regurgitation. I mentioned preload and afterload earlier. So preload is the amount of volume going into the heart, whereas afterload is the resistance that it has to pump against in order to circulate oxygenated blood. Scope of the concept's the same. You're either optimally perfusing, you have impaired perfusion, or no perfusion resulting in tissue death. And risk factors for valvular disease. So congenital diseases, some people can be born with defects. Aortic valve stenosis, for instance, can be something that one is born with, or maybe they have leaflets that are fused together. And then age-related risk factors, so the older you get, you kind of have risk for calcifications due to atherosclerosis and everything. So if you do have atherosclerosis, you're at risk for calcifications developing on your valves as well. Illnesses, infective endocarditis, we'll talk about a little bit later, rheumatic fever as well, but also any injury, dilated cardiomyopathy can cause valve-related issues. So the 2 we're going to talk about that are most common are mitral and aortic. So mitral valve disease, specifically prolapse, occurs in about 2% of population, and a lot of patients can live like this for a long time without even knowing that they have a prolapse. They may not have any symptoms at all, and it's just detected when a physician or a nurse hears it when assessing heart sounds. They may hear a murmur. If it does start to worsen and progress more leaning towards regurgitation, patients may complain of feeling like they have palpitations or chest discomfort. Treatment, again, they oftentimes don't need treatment, but if it progresses and it becomes worse and they're regurgitating, they may need a replacement or a repair of their valve. These patients may also need a daily aspirin too. They may be at risk for like TIAs because the heart, the blood in the heart's kind of just sitting around a little bit more. It's not functioning and pumping as effectively as it should. So regurgitation, so this is, again, when the blood flow is going back up into the left atrium when it should be ejected out through the aortic valve. So patients with mitral valve disease don't really have symptoms, but if it worsens, they're going to be having right-sided heart failure because of the strain that it puts on the right side of the heart. These patients are predisposed to AFib, again, putting them at risk for stroke or TIAs, and also pulmonary hypertension because the pressures within the lungs are elevated because of all of the backup of blood that shouldn't be there. It's kind of like an overload of blood, per se. And also in developing countries, so for instance, the U.S. is a developed country, but those who are still developing or underdeveloped, rheumatic fever can also be a cause of mitral regurgitation as well. And rheumatic fever is simply from strep throat, not treating strep throat. So for mitral valve regurg, treatment would be afterload reduction, anticoagulations to aid in preventing stroke, and also valve repair or replacement if it gets bad enough. And stenosis, so that's when the blood is restricted from the LV to the aorta, and this may have symptoms of shortness of breath and fatigue, again because the blood is backing up into the pulmonary system. It's not able to empty out in order to be perfused out to the systemic circulation. Causes, again, rheumatic fever in developing countries. And treatment would be diuretics to control your fluid volume status, make sure that you're not fluid overloaded, anticoagulation, and valve repair or replacement. And these patients should also be instructed to rest because you don't want their heart to work too hard too if they're doing strenuous exercises. And then aortic valve disease, so regurgitation, simply when the blood is supposed to be pumped out into the systemic circulation, some of it is regurgitating back into the left ventricle, which then puts more strain on the left ventricle because there's excess blood in there. So it has blood coming from the left atrium, and then it has the regurgitated blood coming back down from the aortic valve. So it's a lot of blood sitting in the ventricle, which then can lead to hypertrophy and ineffective pumping. So signs and symptoms with regurgitation would be more of left-sided heart failure. So they would end up with a lot of respiratory signs and symptoms, feeling like they have difficulty breathing. They may complain of feeling weak or fainting even because of perfusion to the brain. With aortic regurgitation, you often hear a high-pitched murmur when you listen to their heart sounds. And then causes would be hypertension, untreated syphilis, infective endocarditis, and treatment. You want to give vasodilators so it can help reduce the afterload. It can pump effectively through that valve, and repair or replacement if it gets bad enough. And again, rest is important for these patients. So stenosis of the aortic valve. So it's one of the most common and most serious valve problems because, again, if the left ventricle is unable to eject all of the blood that it has, some of it's going to sit in there and again lead to hypertrophy of that left ventricle. It's not going to pump effectively. Symptoms again are minimal, but if they continue to worsen, they may end up having some chest pains, angina, syncope, heart failure, and S3 and S4 sounds as well. And sometimes it's best to hear their heart sounds if you have them sitting upright, sort of leaning forward, because then that sort of brings the heart closer to the chest wall. So when you are listening for like your S3s, S4s, you might be able to hear them a little bit better, and murmurs as well. And causes, I mentioned earlier, calcium buildup or scarring. So scarring would be related to if someone's had rheumatic fever and it's affected the aortic valve, could end up with scarring, eventually leading to stenosis. And treatment is medication for dysrhythmias, medication for treatment of heart failure, and then valve replacement. And this is just a short video. Just again, just as a visual.
Stenosis is the term for a valve that doesn't open properly. Here we see a cross-section of a normal heart from the side, and a close-up view of the valve looking down from the top. When the valve is working properly, it opens fully to allow all the needed blood to flow through. In problems like aortic stenosis, the valve doesn't open all the way, so less blood flows through the valve, and the body has a reduced supply of oxygenated blood. Stenosis can be caused by age, or by a malformed valve called a bicuspid valve, where two flaps are fused together, which is present in 2% of the population.
So just a small little visual. So then surgical intervention for valve disorders, valvuloplasty, so that would be a repair of one's valve. So they can go in and either repair just the leaflet that's causing the issue, or if it's the chordae tendineae that's causing the issue, you know, that help to open and close the valve, they can repair that as opposed to replacing. And post-procedure care for nursing, frequent neurovascular assessment is important with these patients, again, because you're assessing for their risk of stroke. You want to make sure that you're monitoring that closely. And then monitoring for vasospasm, dysrhythmias, or rupture of vessels because of how that surgery is so close to so many major vessels. And assessing for pain as well. And then valve replacement, there are two kinds, mechanical and biologic. So mechanical is an actual, like metal, or I don't know specifically what type of metal they use, valve that works as a normal valve. There's a picture on the next page I'll show you. But with these patients, the one thing to remember with mechanical valves is they need lifelong anticoagulants because of their risk for vegetations developing on the new valve. So they're most likely going to be on lifelong Coumadin. And biologic would be a tissue valve, so you've heard of bovine or even valves from cadavers. Those can be used for valve replacements. And initially they may need some anticoagulants, but they do not need lifelong like the mechanical and they may require a second replacement in the future because biologic only lasts so long, on average 7 to 15 years. So anybody who's had a valve replacement should be on prophylactic antibiotics if they were to have invasive procedure like dental work or anything that is involving the mucosa. And do you know why that is? Yep, so infection, so specifically infective endocarditis. So they're at risk for that with valve replacement. So these patients will be taking most likely like an ampicillin or something before they go and have dental work done or something. And these are just the two different valves. So you can see this is your tissue valve here and the artificial mechanical valve that just looks like a little disc. And has anybody ever been able to hear a mechanical valve on a patient yet in clinical or anything? I have this little video because it's really neat when you do get to hear it. It kind of sounds like the clicking of a watch. So you can hear the ticking.
What is this? That's his head.
That's his valve.
Oh, wow.
Yep. So it sounds like a watch.
That would drive me nuts.
Well, you can only hear it
That
when you
would drive me
actually
nuts.
auscultate. You can't just hear it. So
All the sides.
But it is really neat. You don't come across them all that often, so that's why I wanted to show you what it does sound like, so that if you do come across something that sounds like that in your clinical, you'll say, oh, this patient has a mechanical valve, you know. You don't see it that often, so it's pretty neat. And then infectious valve disorders. Infective endocarditis is probably the main one that you sort of want to look at. The other two, not so much, because infective endocarditis is a huge risk factor of like valve replacement. So for studying and everything, I would focus more on infective endocarditis. But basically, it's caused by bacteria carried through the bloodstream. Patients at risk would be IV drug abusers, if they're having invasive procedures involving the mucosal membranes that I mentioned, and also prolonged indwelling catheters puts patients at risk as well. So, again, prophylactic antibiotics before procedures if a patient has a valve replacement in the past. So nursing care for these patients would be auscultating for murmurs. Specifically, if you happen to notice a patient you took care of a few days ago didn't have a murmur, but they've been in here with some sort of infection, and now all of a sudden we hear that they have a murmur, you have to start thinking, oh, could this be infective endocarditis? Is something going on with their valves now? Monitoring their vital signs, especially their fever. These patients will most often have a fever and a high white blood cell count. Monitoring for cardiac tamponade and heart failure. So tamponade, if you haven't heard of it before, is basically just a fluid accumulation around the heart within the pericardial sac. And this is an emergency. So signs and symptoms of that happening would be hypotension. Their heart sounds are going to sound really muffled, kind of scratchy. And they'll have some JVD, or jugular vein distension. So these patients may need like a pericardial window surgery to drain the fluid that's around their heart. And then medications for infectious valve disorders. Penicillin can be given as an antibiotic, and also amphotericin B would be used for any fungal infection. Again, encouraging rest. And then educating patients about meticulous oral hygiene, frequent rest, and following their medications as prescribed. So I just have a couple practice questions here. The nurse is educating new graduate students about the risk factors for aortic stenosis. Which of the following are risk factors associated with aortic stenosis? A, B, and D.
C.
D.
D, yeah.
Mhm. So A, B, and D.
Oh, valve disorders.
Yep, so for stenosis, that's what it would be. Right, because IV drug abusers would be infective endocarditis, yeah. So the nurse is caring for a patient with infective endocarditis. Which nursing interventions will be included in caring for this patient? This should say select all that apply. Yep. A, yes it is. A, B, yep. E. There's one more. C. Peripheral edema, because you're thinking about heart failure with these patients. If it's progressing and worsening, they may have signs and symptoms of heart failure.
So it was
A, B, C, and E.
Oh, not B?
Nope. Because as a nurse, you wouldn't be organizing their home services.
That's like case management.
Yeah. And number 3, the nurse is caring for a patient with a valve disorder. Which assessment finding would be most important for the nurse to intervene? B. Yep.
It's a stroke.
Yep. Because of risk for stroke, it would be B, asymmetrical mouth. All right, and then I just have a case study, or